Kelly Hayes is part of the advanced illness team here at CareOregon. So please give Kelly a warm welcome.
So I'm pinch hitting today, and I have a cold, so I'm gonna do the best I can. I'm newer to CareOregon, but I've worked with some of our partners in the community over the past couple of years, and I'm happy to be here today. So I'm basically going to talk about palliative care in our safety net population and overview, and then Laura is going to get into a more specific case and what her programs entailed through Adventist Health Options. So palliative care is the philosophy and specialty of relieving suffering in patients with serious illness. Since the beginning of the hospice movement in Britain in the 60s and in the US starting in the 70s, there's been a growing awareness of the needs of those with serious illness. In the subsequent decades, palliative care has grown to include not just those needing hospice, but anyone with serious illness who needs support in key areas such as decision-making, symptom management, and care coordination. So it's important to make a note about language. When we talk about palliative care, I mean an overall philosophy of care that everyone deserves when dealing with serious illness. It's the broad definition that includes programs like hospice, but is bigger than that. As palliative has advanced as a priority in U.S. healthcare and increasingly as a core triple aim intervention, it has been focused on the elderly primarily. And this makes a great deal of sense since the majority of people dying from chronic diseases are over the age of 65. However, as the field has evolved, it's been clear that there are other significant areas of critical need that must be addressed in their own specific context. And a good example is in the 90s when we first started looking at palliative care in pediatric populations. They had a pretty specific set of needs, which was greatly different than our geriatric population. And so what's been clear about that is that there are other populations that we can apply that kind of same set of ideas to. And where we've applied that here at CareOregon is in our safety net population. It's a very specific set of challenges serving vulnerable, often traumatized, low-income populations. So I hope to provide you a little bit of an overview of what we're doing. Traditional palliative care is focused on meeting the needs of the seriously ill beyond actual curative medical treatment. It's about trying to improve quality of life and reduce suffering in every way possible. The famous palliative care physician Diane Meyer defined palliative care as 3 domains: symptom management, like pain and shortness of breath, anxiety, goals of care, what do you understand about your situation, your prognosis, what's important to you, and care coordination. In complex illness, it is so easy to become lost in the maze of specialists, facilities, services, and so forth. Now imagine being uncertain about your prognosis with no one asking you about your goals and having major symptoms like pain and shortness of breath, and also trying to navigate the healthcare system. And it's a path that no one should have to walk alone. So since 2010, CareOregon has focused on providing outpatient palliative care to its vulnerable members as a dedicated program. The program started as a benefit being administered by 2 area Portland hospices. Patients were strictly in the outpatient palliative care program, not the hospice. In fact, the majority of CareOregon patients don't even go to hospice. And what we've learned over the years, above all else, is that it's the relationship that matters. As we know from trauma literature, it's the ability to regain trust and security through relationships that is so essential to overcoming traumatic life experiences. So in our model, while we do core traditional palliative care activities, at the heart of it is a high-intensity involvement by our nurses and social workers to create this foundation above all else. As we've learned, without this kind of relationship, the rest of the work doesn't go well. So what do we know about child and adult traumatic experiences? We know that it can lead to altered brain development, emotional and cognitive functioning problems, and associated morbidities like anxiety and depression. Lifestyle problems like smoking-related COPD and substance use. In Oregon, if you are homeless or living with severe mental illness, your life expectancy is decades less than other Oregonians. And the other thing about our population is the younger population. So the majority of our patients are under the age of 65. And even though 80% of all deaths occur over the age of 65 nationally, so that translates into being that our patients are living and dying with geriatric diseases in middle age, like heart failure. So how do we serve these younger patients? And we've really, like I said, learned is through our relationships. Relationships are the change, and the most powerful therapy is human love. And that was a quote from a pretty famous palliative care physician, Bruce Perry. So while we cannot solve a lifetime of trauma and sequela with the palliative care program, we can try to chart a new course around trust, support, and love. In healthcare, I'm not sure there is a less appreciated factor than the therapeutic relationship. It's free, it doesn't have any side effects, and it has a profound effect on things like medication adherence, keeping appointments, patient engagement. We've designed our program so that the therapeutic relationships can develop and with frequent visits by our team members. We meet people in their homes, we get to know their families, we understand what's important to them. We attend doctor's appointments. We're sensitive to their health literacy level. Our approach is trauma informed. We show up and we care. So when we think about the differences between palliative and hospice, we all generally have an idea of hospice that our prognosis is 6 months or less. And there's usually a doctor or somebody on the team that's attesting to that fact. They meet that criteria that hospice requires. They're not pursuing curative treatment or aggressive treatment. There's usually a medical director involved, there's a nurse that sees them, there's a social worker, chaplain, home health aide, and they have access to volunteer services. And they typically are not receiving any kind of restorative home health benefit at all. With palliative care, it's a similar team, but we're not saying that you have to be within that 6-month window. You can pursue your curative treatment. And like I said, you have generally the same team. And if you require skilled nursing care in your home from a home health agency, you can still receive that care. And identifying those patients for palliative care instead of someone sign off like, yes, it's 6 months or less, is the surprise question. And I don't know how many people are familiar with the surprise question. So, great. The question is simply, would you be surprised that this patient died in the next 12 months? And if you're not surprised that that patient would maybe die in the next 12 months, they're probably a good candidate for palliative care. So we have palliative care available essentially to all our members in this Tri-County area, Clackamas, Multnomah, and Washington County, and identified also as having a serious life-limiting illness. So we have several programs right now that we're engaged with community partners and internally here at CareOregon. We have a specialty palliative care team embedded at Compass Oncology. We have a team embedded at OHSU Richmond Clinic with a nurse and behavioral health professional. We have a community-based partnership with Adventist Health Services, and that's a comprehensive team that's seeing people in the community, available to all CareOregon members, and isn't dependent on who your primary care provider is. We have a partnership with house call providers, a home-based primary care program. And we also have our internal CareOregon Advanced Illness Care Team, which really has been serving as kind of a coordinating between our other internal departments at CareOregon, as well as offering some triage and pretty rapid deployment of getting people connected to services. So when we think of, there's the surprise question, but there are other questions that may not, if they're not quite so obvious to you, that we like to look at, that they have an advanced condition, that they are in an active decline, which can be measured by hospitalizations, ED visits. They've had a progressive decline in their activities of daily living, and a nutritional decline, that they're losing weight and they're kind of fitting that failure to thrive model. So these are individuals with multiple chronic conditions with declining function and poor prospects for recovery. They generally have a limited prognosis. And if you really think about it, probably you could answer yes to that surprise question. So to initiate referrals to our programs, there is a referral form on our website. And let's call Julie Ellerman if you have any questions about referrals. We do screen for appropriateness of referrals, but we'd rather have your referrals and talk to you about them than not have you send them if you're worried maybe they don't quite meet it. Most of the people that get sent to us do meet the criteria for palliative care with us. So there's no prior authorization for it, just simply sending in your referral. And these are a couple of our partners. And Laura Macias from Adventist is going to talk to you about a patient that she's worked with, as well as what her team does there. So I think that's it.
Kelly, thank you.
Awesome.
Thank you so much for doing this for us here today.
Oh, sure.
Feel better. Feel better.